Good morning, everyone. My name is Rob McClellan. I'm the division head in cardiology. If you do not know who I am. This is one of our 3 named lectures every year, and I just want to start out by acknowledging Joan and Werner Sampson for sponsoring a visiting professor every year. As you know, it's harder and harder to get people to actually get on a plane, come across the country, and spend a few days with our fellows and faculty. And so we're very appreciative that Joan and Werner are willing to support this every year. So thank you, Werner. Hopefully today's speaker is recognized by some of you here in the audience. Dr. Rick Page was the division head of cardiology here before me, approximately a decade ago now, and I'm just managing to, after a decade's worth of work, fix up all the problems he left me. Rick transformed the division while he was here, and it was really easy for someone like myself to come in and build on that progress, so I actually have a debt of gratitude to him for what he was able to do. He's had an amazing career and has been involved nationally and internationally as a thought leader in electrophysiology and the treatment of arrhythmias. He's been the president of HRS and held numerous roles in the American Heart Association. Last year, he was recognized with a Clinical Achievement Award by the Clinical Council of the American Heart Association. And currently, he is the Dean of Vermont, and he's 4 months into that job. So again, I'd like to thank him for coming out here at a time where I know he is very busy, and express the division's gratitude for him spending time with both our faculty and fellows. So thank you very much, Rick.
Thank you so much, Rob. And having spent last night with, I'm really impressed by the quality of the fellows and all the good things about what you've done to clean up the mess I left for you. It's really an honor to be here with you today, especially in a lectureship that's in Werner Sampson's name. Werner is one of my heroes and became a good friend of mine. And one of my goals in life was for Werner not to retire as chief, because he had a huge practice, and I didn't fill that void. Today I'm going to be speaking about kind of a of experience with it, and just for orientation, this is called the Old Hill, Vermont, and it is that of the Pacific Northwest, in that there are mountains and beautiful lake shapes. The state of Vermont. We'll be discussing the AED as a monitor, which is off-label use of that. This is my other no of interest slide. So let's start grand rounds, as I like it to start, with the case. Mr. Smith, a 54-year-old executive with sudden cardiac arrest. Overweight, hypertensive EO, sitting next to his wife on an airplane. He arrests. And this is his electrocardiogram. What do you do for this? And what would the chance of this individual surviving? Long ago, actually, the American Heart Association came up with this rapid likelihood of surviving critically dependent and really defibrillation. And that's born true, and with survivals even better than they were imagining then. So the first lessons for me were aboard the aircraft, and my work in Dallas prior to coming here with American Airlines. Under the best conditions, flying over land It takes 20 minutes to get an aircraft to the ground, and that's assuming it's landing. Of survival would be minimal if there weren't immediate availability of defibrillation. American Airlines was the first major carrier to place AEDs and training their flight attendants. And for me, this was the ideal laboratory to evaluate the AED in a controlled but remote condition. Just to remind you, an AED is a simple device. You turn it on, you attach the pad. It does not fuck unless you push the button. It's an open automatic population had 200 events with a mean age of 58 years, and 66% were men. The indications used were for loss of consciousness, which is the indication to place an AED, but also over half of them were placed for other conditions, including chest pain or dyspnea. Now, a physician was available in 139 available. We don't know how many times physicians might not have raised their hand, if some cardiac, especially the chance of survival. Actually, in 9 cases, they pulled the device off the air. These flight attendants, now empowered with life-saving technology, there weren't defibrillators in ports, but they pulled the device off and used it in the airport. So back to our case, Mr. Smith. Seconds after turning on the device, he received a shock, estimated and not yet taken off. And 10 minutes later, he was taken off the aircraft, giving a thumbs up to all of those involved for the first save with one of these devices. Now, not everybody had cardiac arrest. These are electrograms from patients who had the device placed for a woman with sync, showing sinus monitor. Palpitations. Looks like he's got appropriately identified the. Now, unfortunately, every patient with cardiac arrest cannot be saved. This was a 52-year-old patient. Circumstance, and this patient expired. So in terms of our series, ventricular fibrillation was documented in 16 patients, was present in 16. In 14, it was documented. The device didn't provide. VF episodes were in 100%, and a shock case. It turns out that in that case, this was a patient with terminal cancer who was flying home to die. F committee right there, the flight attendants request and provide. In patients actually survive not only VF, but to previous survival, which was is use of a monitor for an AED is something that's available in air, not most AEDs. But in the air, I've actually used the device to monitor, in one case, landing a plane. I didn't land it. I landed. Who, with a patient with diaphragm and bradycardia, who I believe was having an IMI but couldn't prove from the monitor. What this provided, though, was an indication of the safety of the device in that no shock was recommended, much less delivered. Now, in this was the ventricular fibrillation experience in casinos. Again, non-traditional responders, this case, security personnel, and the odds were even better there. In security officers at 10 facilities were trained in CPR and the AED use. about a 5 or 6 hour training. Criteria for them, you need to be conscious and unresponsive. And they had 148 patients with confirmed cardiac arrest, and 71% were in VF. Survived the hospital discharge. There was a between those who were defibrillated 3 minutes or earlier, with 74% converted and surviving if they were shocked within minutes, as to still high after 50%. And this was a further test the device, in part because it had videotape of almost all of these arrests. Casinos, whether you're not in a bedroom, someone is, you know. Back to the chain of survival, because I became a zealot for defibrillation, but in fact, that's only part of the chain of survival as put forward by the American Heart Association. First of all, immediate recognition and activation, immediate CPR, rapid defibrillation, then basic and advanced emergency medical care, and finally advanced life support and patient care. And all of this relates to really the 3 phases of cardiac arrest. This is taken from work from Weisfeld. The fact that cardiac arrest, if it's immediate, can be converted to an electrical phenomenon. If you've ever been in the EP lab, you defibrillate or you defibrillate and defibrillate with placement of ICDs all the time, from which you recover almost immediately. On the other, once you get into the hemodynamic phase, right, CPR is very important. And finally, the metabolic phase, the issues of cooling that I'm not going to go into now, the post-arrest care is now recognized as critically important. But let's go back to early CPR, just to remind ourselves of the importance of this. Basically, we know prompt CPR is associated with chance of survival and better quality of life among those who do survive. However, in many environments, not many cardiac often did not receive any CPR, or even less than 25 in some environments. Well, what does CPR do? Action, where it's critically important to have both compression and decompression during the arrest. And based on animals, that your pressure doesn't really get up to a reasonable level, and this is in a swine model, until you've given a lot of pumps. So basically, the idea of in the old days, just a few, 5 or 20 compressions and then a breath, it takes a while to get perfusion pressures up to the rest of the body. But even more important, the same investigators demonstrated that in the earlier days of more frequent breaths, all your effort to get the blood pressure up was then undermined by the fact that you had a relatively long. Now, I don't know whether everybody here is aware, but talking about defibrillation is kind of like bringing coals to Newcastle when you're coming to Seattle. And there are leaders here, Peter Kudenchuk, clearly Mickey Eisenberg, and Tom Ray, early on really made a huge difference in the concept of how we minimize delays between providing CPR by demonstrating that when he looked back at the resuscitation that they had available to look at, 85% of people who got converted were converted with the first shock. And we used to wait for the second shock and wait for the third shock. And the fact is, even the wait, even the check of the pulse, was allowing that blood pressure I showed you to stay low. And the key is maintaining blood pressure perfusion throughout the resuscitation. And for that reason, frankly, the recommendations were changed based on this, so that immediately after you have a shock, you reinitiate CPR. The other thing I'll mention, I actually Rob mentioned that I was involved with the Heart Rhythm Society. I was actually doing a visit to the legislature with someone from the Heart Rhythm Society one day when we drove past that chain link fence, if you know it, outside of National, and there was a commotion, and we turned around, and they were undertaking CPR on a man who looked in his 50s, who'd had a witnessed cardiac arrest. And I've done a fair amount of CPR, as most of us have, frequently in the hospital. And there's no more disheartening feeling than initiating CPR and feeling the ribs break and the chest disarticulating. And that still go on, and we still have a good chance of survival. But that undoes one of the most valuable parts of CPR, and that is the expansion of the lungs. So here I was with a man who was, I think he was cycling and healthy, exercising, and he'd been down for 10 minutes already. And he started making some agonal motion, and people thought he'd awaken, but he was clearly unresponsive. So I actually took over and did a little bit of CPR. And I was struck by the fact that his chest beautifully expanded. And it took another 10 minutes for the ambulance, actually the fire truck, to arrive, because these days fire and ambulance kind of race to the scene. They got there with a defibrillator. I was already asking whether they cooled patients at the hospital they were going to go to. Put up a defibrillator. It said stand, gave one shock. And this gentleman was awake by the time he got on the ambulance. So the point being, good, especially in a patient who has a reasonable chance of survival with intact chest function, there is a good chance that you can maintain survival while you're waiting for the defibrillator. Now, there was a recent 2010 guidelines, and I'd just like to remind of what state of the art is for CPR. First of all, high quality chest compressions at a depth of at least 2 inches at 100 to 120 beats. Now, you tell people to the beat of staying alive, and it's blank stare. But you want to do it fast and hard, bottom line. Single and double do 30 to 2 compression to breathing. For untrained rescuers, hands-only CPR is the way to go, and that's actually taught by 911 if someone doesn't know what to do, and that's better than nothing. And finally, the newer update in this era of opioid overdose is to consider whether naloxone be part of resuscitation effort. Now, how long you do it, as I mentioned, actually can make a difference. A study that was highlighted in New York demonstrated that the AHA got with the guidelines registered that they looked at the time in the hospital, how hard you work to save the life. Those who survived generally had shorter time of resuscitation, 12 minutes versus 20 minutes. But interestingly, there was a statistically significant and clinically reasonable increased probability of survival, 1.12, if you worked a little bit harder. So basically, those who had the longest quartile of working compared to working to resuscitate, compared to those who were in the shortest quartile where they felt it was hopeless, actually working a little bit longer may translate to better. Now, I mentioned our early studies with rapid defibrillation with a defibrillator, but believe it or not, there was some concern. Is this, are they to support defibrillation or defibrillation broadly? And that is what will be the only randomized trial in terms of defibrillation called the Public Access Defibrillation Trial. And this had of evaluating comparison groups, one group with CPR and early response, and the other AED available, comparing in a randomized fashion among the groups in terms of survival. Now, there was this issue, is this a good idea? Should we have these newfangled devices out? Issues that were raised were, you get so caught up with the device that you don't call 911. There's a assumption that people had that they were doing all they could for the patient already. There was a worry that this would delay CPR, and we now know you don't delay CPR. And early programs had been variable in terms of their results. And finally, the cost defibrillators? Is this where our money should be spent? So the PAD trial had 1,000 distinct sites with stable populations of 250 or more. And this included public areas, gated communities, malls, and the like. And they were randomized to the intervention group or the control group. And again, everybody CPR. So they actually gamed this to reduce the impact because everybody was trained in having a resuscitation protocol. It's just some had the defibrillator and some didn't. And these were the results. And it actually reached a statistically significant endpoint with just about a twofold increase in the likelihood of survival from cardiac arrest in those areas with the defibrillators provided. Now, while I was here, the call came for the Resuscitation Outcomes Consortium. Is Peter Kudenchuk in the room? Peter and I had a talk about this, and one of my joys in my time here was helping to convince him that he was the person to lead the group here in the Resuscitation Outcomes Consortium. He participated in the grant and has been funded thereafter for at least the first 2 cycles. But as you can see here, this was the resuscitation, the clinical center as well as an enrolling site, and throughout the United States and Canada, sponsored by all these groups, to put together the data and actually only do that by for randomized. And the first studies that as a mentor of mine has been involved in resuscitation for 40 years, they looked at about 14,000 out-of-hospital cardiac arrests, and 32% received CPR but no AED, and 21% had an AED placed before EMS survival. And the survival is what you might imagine, 9% CPR only, 24% shock that was indicated, 38% survived. And with multivariate analysis, it was clear the AED application increased the likelihood of survival, and this translated to close to 500 lives saved per year. Now, what's the quality of the life? And how does patient? All of these are aimed at out of previous or just quality of life. Actually, a study out of Mayo came out a number of years ago looking at the long-term outcomes. This is the general population at the top, and if you don't have an arrest at all, and you don't have bad cardiovascular disease, you survive better. Here, survival over years. The study cohort in this solid black line are people who had cardiac arrest and were defibrillated. When you do an age and sex match and disease match control, however, you find that the survival of those who had a cardiac arrest is as good as the ones who didn't for their level of cardiovascular disease. Again, emphasizing the importance of resuscitation and the benefits to patients who are afflicted. Now, the issue of where AEDs should be placed is relevant. For example, we can't have them everywhere. I haven't noticed an AED as I walked in. I usually scan for them. But out of King County, a number of years ago, they looked at this, and this was Becker's work back in '98. And they looked at the annual arrests per site, and you see airport, county jail, shopping malls, and these are the number of arrests per year. So at SeaTac, there were 7 arrests per year on average. Going down to senior center, about 1 in 30, and then the ones who had fewer cardiac arrests included hotels, motels, and other areas, construction sites. This gave an idea of where one might want to put a defibrillator. Further data with regard to this came from the PAD trial that we just discussed. A subsequent analysis looked at treatable cardiac arrests and there were 2.9 per 1,000 person years. And there were the highest treatable cardiac arrests at fitness centers and golf courses, and the lowest at office complexes and hotels. Now, in terms of survival from cardiac arrest, they found that recreational complexes, public transportation sites, and fitness centers, there were really quite a high survival. The lowest survival is office complexes and residential facilities. And I might mention home defibrillators. Home defibrillators are not cost effective. A number of people have them in their homes or decide they want them. We've all heard these stories, and if you're entertaining a lot of elderly people in your home, it might make some sense, but chances are you won't be using a home defibrillator, and residential facilities likewise. And one of the reasons is, even though 80% of arrests occur at home, they're usually unwitnessed. And a defibrillator would do no good for you if you're all alone. So in my last few years here, I had the opportunity to work with really some of my great friends, and Mickey was a hero to me even before I came here, looking at sudden cardiac arrest at exercise facilities through the King County Seattle database, and looking at the implications for AED placement in this database. And just to remind you, King County and Seattle are a heterogeneous metropolitan setting. We did a population-based cohort study of sudden cardiac arrest between 1996 and 2008. We looked at every sudden cardiac arrest occurring in an indoor location, and these were classified as either occurring in an exercise facility or a non-exercise public indoor location. So we're looking at out arrest, indoor. And then within the exercise facilities, the question was, is there a difference between the traditional and the non-traditional exercise facilities? And I'll define that in a minute. The reason is there were a lot of, welcome, Peter. Not to shame you. I actually just mentioned you as doing some important work. So have a seat. But the issue being, many states had legislation and rules for defibrillators in 24-hour fitness, but nothing in these other sites. What's the difference? What is the frequency? So we find exercise facilities. A health club is easy. That's a health club, fitness center. Those are traditional. The alternative include basketball. I'll read them here. Just these other places, fuller exercise, exercise, and they're indoors. They're typically around other people. And what are the frequencies? So these are the data in terms of the patients that we looked at. In terms of traditional exercise facilities, we had 52 patients. Their mean age was 54. Most were men. 89. Only 12%. And in non-exercise in survival was 34%. To a number of fewer receiving CPR early, fewer showing VF at the time, and fewer being witnessed. So you'd expect fitness clubs, exercise sites, you might have more people watching you if you fall down to rest. Another interesting thing that we found was when arrested. The most frequent activity was actually basketball, dancing, just generically working out, treadmill, tennis, bowling. 1 in 20 was bowling. And about 1 in 20, a little bit less, was swimming. That may have to do with a number of things, including, as you may know, one of the channelopathies for long QT actually has an increased occurrence in swimming over the others. So the next thing we did is try to look at what is the frequency, because we're looking for your bank book. You're putting a device in, likelihood that it will be used, And we used a National Establishment Time Series database to calculate the number of sites that would be required for some sort of AED use annually. We conducted a web-based search to estimate the number of community centers and hotels with gyms. And then we used these data to calculate the site incidents per year. So what's the likelihood that next year your defibrillator is going to be used? And most aren't used every year, but then again, most fire extinguishers aren't used every year. So this is what we found. Just looking at the health clubs, we had a total of 52 arrests, a lot of sites, and the likelihood of an arrest health club per year was 1 in 42. So at 42, one might defibrillator. I would argue that would be a valuable thing to have. The interesting thing is, in indoor tennis facilities, you only needed 11 before you got a defibrillation. In ice arenas, 13, and bowling alleys, there's that bowling again, 27. So you were more likely to use a bowling alley AED than one in a traditional fitness center, but there were no rules about bowling alley AEDs. And then you go on to community centers, dance studios, martial arts schools, maybe commotio cordis is not that big a deal after all, but this is the information that we got, which really changes around the idea that why legislate fitness clubs as opposed to other sites. And you might think about this, and again, back to the bowling alley. First of all, is this your typical bowler? First of all, it's not the 80s anymore, but this is not your typical bowler. Your typical bowler doesn't exercise, is overweight, and drinking as they're exercising. So what better place to have a defibrillator available? So just summarizing that study, we found that survival at both traditional and alternative exercise sites exceeds that seen at non-exercise sites. The activities during sudden cardiac arrest at alternative exercise sites include bowling and dancing. The site incidents data demonstrate a greater probability of an arrest at some alternative site than traditional fitness facilities, and these data have further implication for community and AED placement. I will point out something with a little bit of embarrassment. I left in 2009, and it took us 4 years to finally put and have it published with the from my standpoint, anytime I write anything that gets attention about defibrillation. Pulling up the ROC consortium, I did, and I thought Peter and that continue this resuscitation outcome just being looking at a database of like 61% were shockable and 19 bystander AED claims. Things are moving in a positive way. They found that the bystander AED associated with 66% versus 43%, and with discharge with favorable, versus 32. Show with bystander shock was 2.62 survival to hospital discharge and 2.7 for discharge with positive favorable. And interestingly, emergency medical service for the data here, and looking at the probability of survival. The dotted line is those with bystander shock. The solid line is EMS shock, and this is over time. And as you might think, First of all, look at this amazing survival with bystander shock. And the difference increases. So while in Seattle, you still get a shock pretty fast if there's not an AED, because this is Seattle and you've got Medic 1 and this is a very well-tuned system. But most places aren't Seattle. And as such, this demonstrates that having bystanders AED available is critically important to survival. Now, my title of my talk was Ambulance to Aircraft and Beyond. And in the decade or so since I left Seattle, I've had the opportunity to not only be involved in aircraft, but be involved a little bit with NASA. And I'd like to show you some data, some published, some not. For orientation, this was our first laboratory, and this is a space station that has an AED on board. So why is this important in terms of aerospace? Well, there were signals already. 1998, this run of non-sustained VT was reported in the literature. Doing a simulation of bed rest, which is the equivalent of as close as you can get to zero gravity, it was demonstrated that LV mass falls. And actually, early data from just the turn of the century demonstrated there was cardiac atrophy in terms of left ventricular mass after spaceflight. You want your heart to stay strong. The likelihood of arrhythmias is only going to increase. And through connections that I made while I was in Dallas, I've been a consultant to NASA in terms of the space program and their arrhythmias. I've got to say, of all the things I've done in my life, I think the only thing my kids think is cool is that I get to read astronaut EKGs every once in a while. Because when they get these things, they want some input, and they've got a good group that they assemble. So I'd like to share with you the integrated cardiac, some data that are likewise growing more and more mature as time goes on, but have now started to be published. And this is a group. Ben Levine and Michael Bungo have been long-term investigators with the NASA program and have received NASA grants, and it was a privilege to work with them. Neither of them are electrophysiologists, so it was a good symbiotic relationship. These are the patches from the various that we've taken data from. And again, of all the things I do, I think this is one of the cooler things I've gotten to do, just in terms of fascination with the space program. And credit goes to the astronauts. Astronauts, if you saw the right stuff, it's not like that anymore. These are middle-aged men and women, and they don't have to be anybody's guinea pig. So when they agree to a study, they are volunteering their body and their experience to the betterment of science. They may even be risking, and this is something you have to be careful with, their career. Because nobody wants to be, nothing good comes from being on a monitor, okay? But on the other hand, you have to keep in mind that the importance of the space program is such that they recognize the importance of their volunteering. So here is activity on ground and in the space station for one astronaut. And this is looking at cardiac work, and they have an active watch keeping track on ankle and hip, basically what are they doing in terms of exercise. And drinking coffee, a little bit of robotic training, that's important. Walking the dog twice. Got on the elliptical for a little bit and slept. Okay? That's on land with normal gravity. And there's gravity in space, microgravity, which basically translates to none at all. But that's on land. In space, they have to exercise. They've already recognized that. And the data I'm going to show you are based on astronauts doing what astronauts do, which is they have no, him being on the elliptical, that's his call. Him being on the STEVIS, and I love these terms, that's a cycle ergonometer with vibration isolation and stabilization system, but NASA loves these things. So here he is on the STEVIS. This is also a treadmill, which in space is kind of cool in that you're bungeed to the treadmill, and because otherwise you'd go up. And but they managed to learn to run, and it's non-negotiable. You're exercising actually a couple hours a day, hard in space, because it was thought that that would help avoid that cardiac atrophy that was already seen in relatively short space flights. In our study, we're actually looking at the effect over 6 months, which is longer than most space flights are, but shorter than those that we'll be doing in the future. So this is a graphic that I think is great. Circulation arrhythmias puts these things together kind of for lay people, and I won't go into detail. I'll show you the data in more of a scientific way, but the highlights were that the cardiac MRI increased LA volume a little bit after 6 months in space. We don't have MRIs in space. That's before and after landing. There's no change in RA volume, and signal average P waves, which we can argue is of very little value to anything, decreased a little bit. But what they're giving you a heads up here on is the different phases of space flight, looking at increasing lunar activity in the 20s and perhaps going to Mars in the 30s, where space travel will be longer. So this is just an example of how they're measuring the MRI for RA and LA, and I mentioned the LA increased in size a little bit, reversible, and the RA stayed the same. Here are the volumes going up in terms of the left atrium and others being flat in terms of the MRI measurements. If you're not familiar with signal averaging, you probably don't be, but just basically you can get the monitor in space without any problem. They have multiple monitors in space. And then you manipulate it so you're actually looking at the waveform, and in the ventricle and in the atrium, a longer tail here, or an overall duration of the P wave, may be associated with arrhythmias. Prolongation of the QRS may be associated with ventricular arrhythmias, but really not a great signal, or in my mind, a significant measurement in terms of arrhythmia risk. Looking at atrial ectopy, almost everybody was flat, except this one individual, C, and these are the 13 astronauts who, for whatever reason, had a lot of atrial ectopy toward the end of their 6-month spaceflight. So that's the atrial story. What I think is more interesting and more relevant to today's discussion of resuscitation is what's happening with the ventricle. And again, this is just demonstrating the manipulation so that there are estimates of left ventricular mass before and after spaceflight. And these are the data. No change. And this is really a great success. And this has to do with the fact some people even got if anything, their LV mass got a little bit higher. Because again, these are middle-aged people. And do I really want to get on the elliptical today? No one's watching. On land, in space, it's non-negotiable. So they are in better shape in many ways after they land than they were when they took off. Now, we saw this is number 4731, pre-flight. You see a PVC. Here you see a 3-beat monoform run of VT for the electrophysiologist in the room. Here's one pre-flight who at night dropped a couple beats. Again, we don't get excited about that. Here's one in flight with 4 beats of non-sustained VT. And here's one with lots of monoform ventricular ectopy. So what does this look like? Actually, there was one astronaut who has a lot of PVCs. It's probably right ventricular outflow tract ventricular ectopy, which is, you may know, is the most common and typically benign ventricular arrhythmia that we see. And this is scaled in thousands. So this is 140,000 over 48 hours in this one person. You see two others that kind of went up. And just to orient you, this is pre, this is various days during, this is 15 days before landing, and this is on landing. And if you take out those three and totally change the scale, this is now 2,000. You do see some movement here, but not a lot. My own hypothesis is that one person does have a ticklish right ventricular outflow tract, and we all know that some patients in certain autonomic milieux, for example, pregnancy, have increased ectopy from that area. I'm not betraying, and frankly, I don't know whether this is a man or a woman, but I know the person wasn't pregnant. And but again, it's something to watch. So from this study, I can summarize, and these data should be published soon in terms of ventricle. Structure and function of the heart are unchanged with vigorous activity during a 6-month spaceflight. When landing on Mars after 6 months, which it takes about to get there, cardiovascular function is likely to still be preserved to allow exploration activities, especially with lower gravity, and likely not too much problems in terms of orthostatic intolerance, again related. Still, not just the heart. You've got different groups with GI, immune system, whatever, looking at how people are doing in terms of time. And in general, though, long-duration spaceflight does not appear to increase the risk for cardiac arrhythmia, and there are no microgravity-specific changes in the. Further, spaceflight is more than just microgravity. Radiation that needs to be considered, especially during very long flight. At this point, no one had been in space for more than 6 months. Likewise, looking at biomarkers and monitoring before and after the flight. And in terms of clinically full risk, again, these are middle-aged men and women, and acute coronary syndromes are probably more concerning risk of arrhythmias or even atrial fibrillation. And this becomes important because I hope it's not like Matt Damon's experience, but you can almost imagine, this is a picture taken from the rover. It looks like you can see the tracks from the rover. You can just imagine setting foot there. We're getting more information in terms of now, you may have followed along, I certainly did, the Kelly brothers. And Scott Kelly was one of 2 astronauts who did a 1-year-long flight. Scott, Mark, who is married to Gabby Gifford, and he retired from the space program after she was done. And the grant to study, they felt they the heart, but they did other twin studies to see what happens when you take one on land and the other put them in space, and they're genetically identical. I will comment that the telomeres look a little bit longer on the one who was in space. And you may be aware that that has to do with increased survival and maybe reduced cancer and other problems, but they normalize soon after landing. There are other studies that are ongoing, and nothing major different has been found as yet between the 2 brothers. So, in conclusion, I hope I've emphasized to you that the AED is proven and important and needs to be all around to resuscitate from cardiac arrest. CPR also remains an important part of resuscitation. Heart immediately, do it hard, do it fast, breathe if you feel comfortable, and it will improve survival. AEDs should be placed at fitness centers, but also at alternative exercise sites. And the next frontier is outer space, where we hope the AED will never be employed. And with that, I want to provide my thanks. This is up on my wall in my office. It was in my wall in Wisconsin. It's on my wall in Vermont. You'll recognize that Packer there. And I want to acknowledge Werner Sampson. Again, a great friend, a hero to me in many ways, and I can't imagine a greater honor. Professor, for your attention.
We'll take a question at this time.
Thank you, Rick, for a fantastic journey from bowling alleys to outer space.
Yeah, there you go.
Coming back to Earth, one of the challenges with public access defibrillation has been, where is the defibrillator? Like if I'm sitting here, or I'm at the airport, or I'm walking down the street, and someone collapses next to me, I can start CPR, but where's the defibrillator? And some places have experimented with phone apps where you can sign up, and my app would go off saying somebody just fell over in the room next to you, and it would also tell me where the defibrillator is. Is that the solution, or how are we ever going to find the defibrillators?
Great question, and everybody heard it okay. How do you find them? If they were like fire extinguishers, we don't need an app to find a fire extinguisher. You can see it in the room. Well, most rooms. But I bet it's right outside. That's probably not going to be the case, and it's probably not cost effective. So the next issue is, how do you find them? I'm aware of efforts to develop an app and the like. There are efforts, I can't remember the chain of restaurants that, actually, it's a great idea because it was ours. I wrote an editorial about this, and the idea of every Starbucks having a defibrillator, if nothing else. Everybody knows where the Starbucks is. I actually got in touch with Starbucks after this editorial we wrote, because it was about another AED study, and they said that's really interesting, and never heard anything more. But it's a good question. It would make sense, and the conflicting issues are, you want these as cheap and easy as possible, and if you then put in some sort of system where it tells the world where it is, then it will be less cheap and simple, but it's a trade-off. Great question.
Thank you so much for the talk. With the sort of increased availability of consumer technology and heart rate monitors and sort of the new Apple Watch with the monitor, I can see you shaking your head. I know this is probably something you get asked a lot.
With joy.
Yeah, of course. I'm wondering if you had seen any data coming out early, or if you think that there is benefit to the dissemination of this technology to prevent bad outcomes.
Well, the Apple Watch game changer. I saw my first patient who has AFib that was found by his watch just last week. The Cardia device, which, if you're aware, the first generation, it was an Apple Watch, the iPhone case that actually had it, and now it's this little thing, and you may have seen it on TV. You may have seen a past president of the Heart Rhythm Society talking about it in a commercial, which is interesting. I believe any AFib that you discover is AFib that's valuable. So I think it's only going to be a good thing, because as soon as you find AFib, if we find it in clinic. I also saw a patient last week who was there because of a hurt ankle, and they took the pulse, and it was irregular. He got an EKG, and it's AFib, and now the patient has AFib. I don't know how that AFib is any less valid than the AFib that's discovered on a watch. And from my standpoint, you evaluate the risk factors, do a CHADS-VASC, and if you believe in it, do a bleeding risk assessment, and then treat appropriately. So I think it's great. I think it's fantastic. Yeah, Dave. It doesn't work very well. A chest thump delivers estimated 0.4 joules. So it's a little shock, okay? If you're in VF, it will not break, okay? You need to be beyond the defibrillation threshold, which with an AED at 150 joules or so, and the wearable defibrillator, I think is joules. Basically, you've got to have lots of joules, and 0.4 will not do anything to AFib, and it won't do anything. It might convert a VT, it might convert a reentrant rhythm, but then it's by chance. So while it doesn't play things much, it plays things a little bit. Now, it occasionally, we've all heard before, someone gets thumped and they say, what'd you hit me for? So, but they might also, when you start pumping on them, say, why are you doing that? So it's not part of the resuscitation algorithm because it doesn't work. Well.
Yeah, I was intrigued by the data about the LV mass, but I thought it was the initial sort of reduction in LV mass was proportional to body mass, and it was just sort of part of the general condition. Was there proportionally more LV mass reduction than total body mass in the second part of it in subsequent studies where you actually saw small increase certain individuals? Did that correlate to a change in mass or to the changes in atrial size that you, like, was there any correlate to those limited number of folks who appeared to have?
Yeah. In terms of the loss of LV mass, you ask a great question, and I'm not sure I know the answer. I believe it was independent of overall muscle atrophy, but I can't say that for absolute sure. In terms of arrhythmia risk, for me, it seems just as important because if the heart's weaker, that doesn't help a weaker body either. But it's a good question as to whether they're dissociated. I don't know. The second part of your question, in terms of those who got better, we don't have the specifics over who exercised and who wasn't, so I can't really say. And they didn't change much. But what was reassuring was that as a group, they didn't go down, and if anything, they went up a little bit. And again, what we believe is related to that is a non-negotiable daily exercise regimen that they wouldn't have been allowed to go up in the space station if they hadn't agreed to do that every day. That's not an experiment, that's saving them.
Great. Let's give Dr. Page one more round of applause.
Thank you.